Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric OKelly. This week, we're publishing the second half of the 2.5-hour podcast that we recorded with Dennis Jarema from the Prolonged Field Care Working Group. Last week, we talked about improvised technique for massive hemorrhage, airway, and breathing emergencies. This week, we'll talk about circulation improvisations and how improvised medicine can help during prolonged field care. Now, let's rejoin the ongoing podcast.
So, circulation, we're going to talk about rehydration, minimum, better, best. So the best option is IV solutions. That's kind of the gold standard. But if you don't have them, then you want oral rehydration, which is the better option. And with ORS, and I mean, that's the best option. But if you don't have that, you need to get the go to hell option. The minimum option would be dermocolysis and proctolysis. We'll talk about that next. So dermocolysis is when you use a butterfly needle to put fluid into the adipose layer of the skin. And the World Health Organization have tons of literature on this, and this saves so many lives every year of people with diarrhea or cholera or something like that. They're infants. You can't get a line in. You don't even have normal saline anyway, and you can't get ORS into the casualty. So they use this. And the trick with dermocolysis is you can infuse 1 milliliter of fluid per site per minute. So that's not rehydration unless you get a whole bunch of butterfly needles and you put them all over the body. And then you can do 1 mil per site for 10 sites. That's 10 mils per minute. That's 600 mils an hour. Is that enough to keep someone alive?
Well, I mean, you're at least an adult. Just maintenance fluid is at 125 an hour, roughly. So you would definitely be over and above maintenance. I guess I would say, what is his urine output? You know, are you able to hit your goals with that to find out if your infusion is enough? I'm just wondering, like, how many sites, how much fluid are you able to kind of set up to do that just through the skin? And why would you not do rectal fluids instead? That's got to be more comfortable than having, 4 or 5 needles going into your tissue and ballooning out because of fluid.
So we'll talk about proctolysis next because there's good science on that. I've had this done to me in class numerous times, and it's not that painful. And one mil per minute isn't, and it diffuses. So you're not getting, in tactical medicine, you have the camelback. Was it the puppy camelback, right? So you get the scruff of the neck of the dog, the canine, and you put in 500 mils, and it balloons up. That's not what you're doing here with this, 22-month-old cholera patient. So 1 mil per site, it dissipates, and so you're not getting as big. You're right. If you put more than 1 mil, if you screw up, you put 7 mils in, 8, 10 mils. Oh my God, the pain of that would be horrific, because now you're causing tissue damage as you infuse that much. So the World Health Organization suggests 1 mil per site per minute, and I can speak from maybe because I have a lot of adipose. As pushing 60, I have a survival pack, but it hasn't hurt. And so the original, the first injection, as the needle goes in, that stings a bit, but then as long as you put normal saline, it's not going to be painful. If you put sterile water, yes, that's going to be quite painful.
Would LR
dermocolysis?
Would LR be okay?
Yep, Ringer's lactate or normal saline. Hartmann's, we call it in Europe, Hartmann's solution. So that works because it's balanced. That's what we're looking for. And maybe Hartmann's or Ringer's would be a better option for a cholera patient anyway, just because of electrolyte and balance. But there's a lot of research in World Health Organization. This is where we nick this from. It's science backed. We're not just having some crazy ideas here. So you can put and my favorite spot for me is, of course, in the belly, because I'm Irish and I like a pint. Then I've got a big belly. It works. So you're not going to do this in muscle tissue. It definitely needs to be sub-Q and needs to be in the adipose if you can. So you mentioned procto. So let's talk about proctolysis. So this also has science. Most of it case study, but we do have some decent science on proctolysis, Murphy's grip. So you can absorb about half a liter per hour, depending on your size and your hemodynamic status. So you can take up about half a mil per hour rectally, but you have to make sure that you're injecting saline, because only saline, 0.9% saline, is going to be absorbed by the goblet cells in your large intestine. So that means if I just put water, normal drinking water, in the rectum, it's not going to absorb as quickly, because the body has to make it not 0.9% before it can start absorbing it into the tissues. And on the other side of that is salt water. So salt water is 4%. So if you put salt water rectally, you're going to dehydrate the casualty, because water follows sodium, doesn't it? So you got to make sure that you are at 0.9% or 1% saline when you do a rectal infusion.
Now, can you? I've heard.
Yeah, go ahead.
I've heard that you can just use ORS, like any kind of like Gatorade or something like that.
As long as it's got salt in it. So the problem with Gatorade, why I don't like those sports drinks, is because ORS, when we make it in class, it tastes like rubbish. It's just horrible, isn't it? It's salty, and you got potassium in there as well. We did give some baking soda in there, and it's just ORS is horrible, and no one's going to pay money to drink that. So all these sports drink companies will just put 10 times the salt or the sugar, so you drink it. So I wouldn't put sports drinks rectally, because it's sugar, and I would prefer just normal ORS. And I remember in selection, they gave us ORS packets. I don't know if they did that for you as well. And when you first left week one, well, actually we weren't in the woods too much in week one. Week two, it started getting really difficult, and the ORS packets started tasting better and better. I remember when like end of week one, week two selection, and the same with the Q course. So the longer you're in and tabbing and working hard, you're losing electrolytes. The more you like the taste of ORS. So I'd always start with like half of a normal ORS packet for a canteen, and I would be able to get it down. Like by week three, team week of selection, it tasted like milk. It was absolutely fantastic. And that's just the electrolytes of seeping out. I mean, I was lucky. I went through in April, so it wasn't like Fort Bragg in August. Selection must be horrible. But what month did you go through?
I went to selection probably like October. So it was like the beautiful time to go through selection.
Right.
However, I went through phase 2 in like July, which was the opposite end. So yeah. I 100% understand your love for ORS in that environment, because you're supposed to mix it in a 2-liter and sip it. But by the end, I was just putting it in a canteen and just loving life.
Yeah. And when we make it in Malta in our courses, it doesn't taste like milk. It tastes awful. And this is what you need to put when you do proctolysis is a good ORS if you can. And how you do this. So proctolysis is you need to put a soft or a malleable type of hose. So a camelback pipe, camelback hose would be perfect for this. Because if you have anything that's like an ET tube, it's kind of stiff, isn't it? And you're just going to risk perforating the bowel if you put something kind of semi-rigid in there. So it really does have to be something that just kind of wiggles around a bit. So IV line works, I have not had good success in training on getting it to go up the full 20 centimeters that you need it to go in. So the rule of thumb is whatever you put in there needs to go 20 centimeters in, which is about two of your palms widths. What is that? 12 inches? It's been so long since I've thought in inches. You want it to go in about 12 inches, and then you can start infusing. And you put in a bolus in about half a liter or until they feel pressure, and then you just wait. And you can try putting in more every half hour or so, and then they'll let you know if it's so. If you put too much in, it's going to come back out, isn't it?
Yeah. Well, I
So
think the
you
key
want,
with that is making sure they're on their left side, because I've seen it where they're
why
on
is
their
that,
back.
Dennis?
They're on the
Yeah.
back, and it just comes right back out. So by putting
Straight
them on
back
his left side, it drops into the descending colon where it kind of boluses and then it gets absorbed. Otherwise, you're just doing an enema.
Yep, which isn't helping anyone at all. Least of all the medic.
Yeah. Well, I
So
mean, you feel nice and clean.
Yeah, he does. You don't. Yeah. So a pliable hose that needs to go up there and make sure that if you cut the Camelback hose, you cut it straight across. If you have it kind of at an angle, that could be a sharp bit that could cause some perforation. What you don't want to do is, every proctologist doc who's listening to this right now is freaking out because it's so dangerous. If you perforate the bowel, he's dead. If you're in an austere environment, he's dead. There's no antibiotics in the world that's going to keep him completely safe. So this is really, really serious, and make sure that you don't screw this one up.
Maybe a dumb question. Would you be able to do a Foley if you're able to get it somewhat rigid to actually go the direction you want and then infuse through the Foley?
Yep, it's super pliable, but Foley would be a good one, and I would say as big as French as you can to hopefully get in the right direction. And
there's a balloon on the end of it to help keep it in place.
And there's a balloon on the end of it. There is indeed. Yep. So a Foley would be a good option if you could figure out some way of getting it up there without
it just coiling up.
Without coiling. We've discussed this. So like, okay, so you get a plastic stylet from an ET tube, and what's the chances of causing perforation? Pretty high, actually. You got it. So tape it. Do you tape it to the stylet and then push it up, or just there's a lot of science on this. We got to figure out the best way to do this because it's really dangerous in a hospital, let alone doing this out in the middle of nowhere. So, I mean, if all you have is a tubby tip 60 mil syringe, I mean, you can at least just keep putting water up, even though you're not getting 20 centimeters into the rectum. So you can at least try that, and that's better than nothing. Yeah. Do you teach this on the course?
We talk about it.
Good.
I've yet to do it because nobody's volunteering. So, I mean, I've seen a lot of like temperature probes and things being used. I think if you're like, nobody's doing this on the X, so you're in a place
this
where
is prolonged field care.
you're in a place where you can chill out and be careful. I think if you were able, let's say you did use a Foley, and let's say you did put a stylet inside the Foley, right? So that everything's covered up, and you can then remove the stylet. You got plenty of lube.
So that's a really good idea because you have some of the tri-lumen devices, don't you? That one of the lumens of the Foley could be the stylet. Is that what you're saying? That you put the stylet inside the Foley?
Inside the Foley where the urine would come through.
Fair enough. Yeah.
And you're able to advance it. I mean, I don't know. Was that
20
12
centimeters.
inches? 12 inches at least,
Yeah.
right?
Yeah.
That's what I tell everybody. But but you're able to kind of feel that internal sphincter release, okay?
Yep.
And from there, this kind of Sellinger technique, you're just pushing it through so that you're not
Absolutely.
banging into that curvature from the descending colon into the rectum there.
Right.
And then at least try, a 60 cc bolus. Does it go in or not?
Right. No, I think that's yet another reason I have a Foley. How many ways do we need to have a Foley
Right.
available for everything? Yeah. So possibly a big one just for this.
Yeah. But I mean, if you're talking 500 an hour, like that's not that fast. That's a burn calc, initial bolus. So you're still doing what 20 drips a minute, 20 drips a minute or so. So like one every three.
Right.
So you're not talking a rapid infusion.
Right.
You don't have to. I don't think you would have to bolus it. As long as the max is 500, so set your drip for that and, start measuring.
Yep. That's a good idea. And I've never actually done a drip. I've only done boluses just so I have a good idea what's going in. But yeah, you could put a drip in and keep an eye on it. Absolutely.
Or, I mean, of course you can bolus it. But like you don't have to. As long as you're keeping up with your input and getting your output that you want, if it's not broke, don't fix it.
Right. And it's all about urine output. That's what, yeah. So this works if you have a burn, like you talked about burn resource. So this can work. And if you add to that dermocolysis and proctolysis, you do have a good recess option. I want to put a caveat out there for people who have seen some random bushcraft survivalists videotape themselves doing this. Don't do that. Don't do what you kind of see on some of these wazoo options. Make sure you do this scientifically, which this is in PubMed, and just make sure they're in the left lateral recumbent. Make sure that you don't overinfuse, and just monitor the urine output, and you'll hopefully be able to evac this guy. So IV sites are notorious for getting infected, and this falls under circulation, I believe. So in hospital, we are very careful with placing IVs by making sure that we clean it with HibaCleanse or some way to clean the skin, and then we put an offsite over top, a see-through dermal tape. In austere environments, we don't have that option, so we teach cling film or saran wrap for those of you in North America. And there's 101 reasons to have cling film available, have a roll available to you. But what we teach is we cover this, the offsite with this, the IV site. And what we found is it secures it and allows you to monitor it. But more importantly, it's just keeping sand and stuff from getting into your IV site whilst you can still keep an eye on that. And then we'll still wrap the IV site around the thumb.
Yeah. Normally I see guys using just op sites, right? But you can definitely run out of that. I guess the downside of just the cling film is the tube is, I don't know, 12, 18 inches long.
I'm glad you mentioned that. So they're not for us. We cut them down. So if you go down to a normal home store and you get them, they're long, aren't they? So we bought a pipe cutter. So I've tried cutting it with a knife, and it's possible. It just looks ugly. So get a pipe cutter, and it makes a really clean cut. And I will cut a normal saran wrap into threes. So now it's 10 centimeters wide. So you're right. So that's one problem, is having the saran wrap too wide. But once you have 1/3 of that, what other problems are there, Dennis?
I would say early, it's okay. It's not going to secure it. that well. I mean, unless you really snug down on it, you're not really securing your site, so you have to back that up with tape. Not a big problem, because just know it is what it is, right? You get to see.
Yeah.
The only thing I can, off the top of my head anyway, is especially with burns, it's, yes, good, you can see it, but because it's taking the air away, different anaerobes love, anaerobic bacteria, love that space. I'm forgetting the name of it off the top of my head, but you make it a really good site for that type of infection.
You're right. That does change the problem from aerobic bacteria to anaerobic bacteria. But with burns, we cover burns after we've cooled them. We've covered them with cling film because it reduces pain. It does stop the bacteria floating around in the air to land on it. But it also keeps the fluid from being evaporated in. So we're a big fan of cling film on burn once it's cool. So the first 20 minutes, you're rapidly cooling, warming the casualty, cooling the burn, and then putting cling film in strips on the burn, because there's nothing better out. Well, if you have hundreds of euro available and you can buy some of those burn dressings, yeah, there's science behind them. But in austere environments, we don't. So
yeah, I think
film is
the key, like you said, is you cut it into strips. You don't want circumferential wrapping because it's going to swell, and potentially at least cause a tourniquet-like effect.
Dr. Winston DeMello is really big on the pain side of things. He describes the burn pain, and because the nerve endings have been, the skin is burned down to the nerve endings are now exposed to air. And so anytime air hits those nerve endings, it's just horrifically painful. So by covering it with cling film, you stop the air hitting those nerve endings. But then there's the three other benefits as well, like keeping water in, keeping bacteria out, and the pain is worth it. So cling film for tons and tons of reasons. So we do use the cling film to secure it, and we are circumferentially wrapping 2 or 3 times on that site to keep it secure. And then here in Europe, there's a drug port on which you guys don't have in America, which I'm kind of shocked. It's so awesome to have that. So you just tear a little hole in the cling film right above the drug port, so you can access the site without having to remove anything. And I've just noticed with the off sites, it does secure better than a cling film wrap, but the site where it goes into the skin isn't covered. And that's where the bacteria can travel down the catheter. So maybe both options. One, you get the offsite. Second, followed it on by cling film.
One other option, we've just started trying it out, so I don't know how well it works quite yet. But tattoos, once you get a tattoo, they put that cling film over top.
Yep.
But they come in short rolls that are about 3-4 inches wide, and that sticks like really well. Like that's made to stick and last, for whatever, however long it stays, a couple weeks. So that's something that we're looking at.
And that's more robust. It's probably thicker than a normal cling film, so it won't tear as much.
And that's made to last.
Moving on to circulation is knowing what the heart's doing. So we'll talk about ECGs. And as a critical care paramedic, I'm a big fan of them. I think everyone should have them. And with the technology nowadays, there's so many small options for ECGs. This is what I carry in my computer bag. It's about the size of half of my palm, and has a little thing for you to see the pulse oximetry, as well as a 2-lead. Now, then there's tons of these out there. They've been around now for a while. They're just getting better and better. So these check. Basically checks 1 lead at a time. So I found a study in PubMed, and it's here if you want to scan. If you come and you listen to this podcast later with the access to the video as well, this, you can scan the PubMed research on using a smartphone watch or one of these 2-lead ECGs to get 9 leads. And we teach this during the eye care course, the intensive care course, and show that you can use the watch. No, it doesn't have to be expensive watch anymore. I've got a kind of a crappy old Samsung watch that still does ECGs, and I do this on myself to check my heart rate or check my own because I'm getting old. Check my own rhythms. I've used this in anger. So I was at a conference in Bydgoszcz, Poland, and somebody had an acute stress response from some SIMs going off, and she started wigging out and hyperventilating. I used this on her to get at least a 2 and 3 lead to make sure that there wasn't a cardiac event as well. So, I mean, loads and loads of people have smartwatches now, and you can use this on the Eindhoven triangle to get 9 of your leads. Now, the augmented leads, there is a way to calculate that. And if you look at the study, they'll show you how to do that, which is arduous, but it is possible to calculate AVL, AVR, and AVF. But in all fairness, if I get my 1, 2, and 3 lead and maybe the V4, I'm happy enough on my cardiac patient.
Yeah, I have one very similar, but it has a plug-in that you can have 2 leads, so you don't have to.
Even better.
You don't have to touch to the metal pads. You can just move them around. But
Which one do you have?
It's like it's a Chinese one. It's like Amazon.
They all are. Yeah.
Right.
Yeah.
So not
Yeah.
only,
Yeah.
but the good thing with the app is you can send it to somebody. You can share it.
Yes. Yep.
So, at least the provider that you're getting advice from can get it while simultaneously updating the Chinese on your patient. But
Yep. So I have it, so it sends to my phone in a PDF, and then I can easily send that PDF. Now the problem is it winds up being one PDF for each lead. And if I'm in the office, I can cut and paste and make at least a 9 lead ECG sheet. But hey, you know what? It's better than nothing, and it allows you to see your casualty if you have a cardiac patient. So old sergeant majors or old team sergeants that are walking around, some old warrants, it's probably a good idea to have the ability to do cardiac assessments in resource limited. So improvised eye wash, we're kind of getting to the end of C circulation and moving more towards prolonged field care, but we can talk about the eye wash option. Use a nasal cannula, and the difficult thing of getting the nasal cannula to work. I mean, you can put it right at the bridge of the nose, of course, so the fluid goes both directions. You don't cross-contaminate the eye. The hard part is getting that oxygen attachment on the other end to something that works. You can't just put it in a Christmas tree and have water come out of it, right? That's used for oxygen. So what we found is you just get a Nalgene or a sports bottle. You shove the end of that, the other end of the nasal cannula in, and you have to plug that hole with either tape or some sort of cloth, and then you can get your fluid running. Urine catch. So this is also part of C circulation. Urine catch is probably one of the number one things that you should be on top of, and making sure that they have their 1 mil per kilo per hour as coming out. So we teach a whole bunch of different ways of doing this, and I got these pictures from the Prolonged Field Care website where some yoke is using a glove, and I like this photo, a glove with an IV line. And I'm sure all medics and docs and nurses out there have done tons and tons of urinalysis and seen how the stream comes out. Do you think that a stream of urine would be able to go through an IV line?
Not so well. I mean, you have to have a vent on the other one at your catch bag. You have to have a vent because otherwise it's just going to back up.
Yep. And you can try to catch the backup with a exam glove, but they break. My favorite is just get a used IV bag, cut a hole, cut one of the corners off, and then use that to catch urine, and it's already got a granulated cylinder in it, so you can see precisely how much fluid they've come out. Now, this works for blokes. For women, you can use a Shiwi. So we don't carry one, do we? But we do carry an eye gel. So a number 5 eye gel can be used as a Shiwi. So you'd have to get the patient to stand up if you can. If they're in a stretcher, you can lift the head up to like 50 degrees, 60 degrees, and try to do the Shiwi catch where it then dumps into the used IV bag, so you can monitor it. But it is possible. I would suggest having and once you use it for a Shiwi, put a red piece of tape around it so you don't use it for something else.
Yeah. So I've tried, they call it the Texas condom cath. So it's just just like the name, right? It's a condom that sits over top, right? Again, works for males. The downside, because everybody just says, well, I'll just stick a Nalgene bottle. Like, okay. But I think catching the urine not as nearly as big of a problem as getting reliable urine output, right? If you don't have something that goes through the bladder, then you're kind of relying on that bladder to get so large that it pushes open the internal and external sphincter, and then they pee, right? A lot of drugs that we're giving are cholinergic, and that causes fluid retention, right? So it's works in that you can catch the urine, but just getting a reliable urine output, like you're going to have to give so much fluid that the bladder expands, and then when it contracts, when they finally piss themselves, it's only going to shrink enough that the pressure, that internal sphincter is able to close again, and then it's going to build up again. I think a really reliable way outside of this is just using ultrasound to measure the bladder. You measure length, width, height of the bladder, and that gives you a volume of a cube, and then essentially you cut that in half, that volume in half, and that's at least the estimated bladder volume. The butterfly and maybe some others as well, but there's an automatic feature. You like hit a button and
that's awesome.
It calculates it for you. But if we're catching urine, then you're doing a resuscitation. So you need reliable output in order to adjust your treatment by it. And I'm sure you can with this, but you just have to understand, like, you're not going to get urine output every hour if you're waiting for this guy to take a piss.
Yep, that's a valid point. Dennis, would you use the IQ butterfly measurement as a reliable urine output, even though the urine is still inside the bladder?
I mean, if I don't have a Foley, and I don't have just a straight cath, so that's one of the things that I asked for in our tax set review is putting straight caths in there. They're small, they're cheap. You can have a dozen of them in a very small container, and you just take one, you do periodic measurements, and drain the bladder. You can put it in whatever container you want, and essentially you just clean it, stick it into a baggie. Obviously, you want to keep it as close to sterile as you possibly can, and you save it. I mean, people do this as their life. Paraplegics and things like that. They do this every day, multiple times a day. So it's definitely a thing. And I have control. Like, it's roughly an hour. We're going to drain the bladder, get your measurement, and then adjust your treatment. But if I had none of those things, I would think, again, thankfully, I've never had to do this for real, but measuring the bladder and using that to calculate my fluid volume, I would think would be more reliable than waiting, 2 hours, 3 hours for that bladder to finally empty or come to give me something, and then have to kind of measure that over. I mean, it could be, especially somebody's volume down, it could be like 8 hours before you finally start getting a trend. Again, I've never been in that spot, but I could imagine if you're just waiting for that pressure to relieve, it's going to take you a while to finally get volume enough to start averaging it over X number of hours.
So an ultrasound and a straight calf. We've been focusing on measuring it as it comes out, but why? Yeah, now that we have the technology, why not do it inside the bladder and then use a straight calf to get all of the urine out of the bladder? You're starting from zero.
Yeah. I mean, once it's in the bladder, like he's not going to absorb it. So like it's going to come out.
It's just making sure that you have a measurement and then you zero out the amount that's there and then get another measurement. But
yeah,
I hadn't thought about that. That's pretty clever.
And is it perfectly accurate? No, a Foley would be a lot closer to accurate, or a straight cath would be a lot closer to accurate. But like we need like timely information if you're doing a resuscitation.
So we're talking about sea circulation means bleeding, and talk about Band-Aids or plasters. Here on this side of the pond, they're called plasters. In America, in Canada, they're called Band-Aids. But you can improvise this with just some tape, so duct tape, and you even do wound closing with duct tape. And I always put holes in the duct tape to make sure the skin can breathe, because if you put just duct tape on the skin, it's just going to warp the skin. But if you put holes in it, it'll help out. And if you're going to use this for closing minor, very, very minor lacerations, you want to clean the laceration first, of course, with copious amounts of fluid and everything else. But when you finally close this, I use the bend joint tensioner to make the duct tape last a bit longer. But I'm not sure what are you using for improvised wound closers?
I've done this a bunch of times as a redneck at heart. I've duct taped my different parts of my body closed many times, and it works. It just works.
Do you poke holes in it, or do you just let it ruin your skin?
That's actually a much smarter way. I just let it ruin my skin.
It works.
Yeah,
it might be redneck, but
just if like a paper towel or something underneath to help absorb fluid. Yep. So maybe that added space allowed some air to get in, but just duct tape it.
Yeah, big fan of just a paper towel, and everyone's worried about sterility. Well, the wound's not sterile. Just cover it. You'll be fine. So let's talk about irrigation. Definitely part of sea circulation, and we irrigate wounds. Rule of thumb at the college is 3 liters. 3 liters of water you're willing to put in your eye. So you're not going to put any other thing into the wound than that. So growing up in the 60s and 70s, I'm sure it's the same with you, Dennis. Iodine for everything, right? The mom was like, "Oh, you cut yourself, tons of iodine. We know it kills bacteria." Well, now we know it kills everything. So when you put iodine or anything else that's going to kill bacteria, is going to kill you as well. So no bleach, iodine, no, just water. And if you want to make 0.9%, brilliant. But you can just put normal water. And I like to say, when I teach this, what causes infections, and it's 3 things. It's bacteria count, it's bacteria hotel, and it's bacteria food. So if you can get rid of those 3 things, you're not going to have a wound that gets infected. So bacteria count means that you're going to use 3 liters of potable water to irrigate out this wound to get rid of the bacteria that's there, and a lot of them. Bacteria hotel is where they can hide from your body. So any foreign body type gravel or anything sticks, you got to get rid of those because the bacteria is going to hide from them. And the bacteria food is dead tissue. The bacteria love dead tissue. So when my mom, who was a nurse, funnily enough, put iodine into my scrape, she was killing a lot of my blood, my cells that would then make food for the bacteria, losing cool points. So now we're just irrigating, pulling all the bits out if we can, and then we don't want to kill any more of the cells, and then we can close it or do a wet to dry dressing.
Yeah. The only thing I would add is be careful of the amount of pressure that you're using. You know, if you're doing like the 60 cc syringe, you know, with like an 18 gauge or something like that, you can definitely generate enough pressure to actually push bacteria deeper in.
Yep.
So just low pressure, large volume. Just essentially just clean water. Soap and water works as well, but just low volume.
Yeah.
Or low.
Soap will kill your cells as well. Soap and water on the outside of on the skin around the area, definitely.
Yeah.
Big fan of that.
But just clean it, you know, and if you do put iodine, or you do put just, you know, dish soap, or it's like antibacterial, whatever, you know, lavender scented soap, make sure you go back and irrigate that stuff out, you know. So it's okay to use regular soap and water. It's okay to use iodine as a scrub, but make sure you irrigate all that out real well. You know, like you said, with your, you know, 3 liters or more of irrigation.
And this splash guards are really important because you don't know where this yolk has been. So even if it's your teammate, you don't know where this guy has been. So splash guards are really important. And in hospital, when I've worked in the A&E department they have these specially made splash guards that fit perfectly onto IV bags. Well, I'm not going to carry that. I'm a lazy medic. I'm not going to carry anything I don't have to. So my favorite thing is to get a Ziploc bag and cut cut a corner off, and then stick my needle, my catheter through that corner, and then I have something that I can keep from splashing stuff in my eyes. You can try using your hand, but it's not the best option out there. There are a lot of irrigation options. The Wilderness Medical Society has said that 18 gauge catheters are probably the best option because it causes 18 psi. But Dennis, you're right. You're even though it's an 18 gauge catheter, you're not torquing on the end of that syringe. You're just doing a normal kind of a dribble or a bit of pressure because you don't want to shove that bacteria into crevices, do you? And I found Camelback is fantastic. Camelback is a good way to make this happen. This is a picture of one of our students in Malta using a used IV bag holder. You know, the IVs come in the IV bag protector, and he used one of those as a splash guard. It was quite clever. So let's talk about hypothermia. So in the March algorithm, we're down to H, hypothermia, head injury. There's improvised neck braces. Now, I'm a big fan. We don't use the store-bought neck braces at all. They cause ICP, but there's a link to a study here that I got off of PubMed where using a sweater can help stabilize the neck and basically remind the patient not to move the neck. It's more of a reminder than it is an inhibitor. What are you guys using for neck immobilization?
We're tactical medics, so we don't use anything. But no, I've seen boots on the side to help stabilize. But yeah, that's usually, or some kind of just clothing, padding, something. But instead of going around the neck, it's just more to keep their head in line.
Yeah, that works. Boots with sand in it. I've seen that work just to keep, and it's not to mobilize anything. It's just to remind the yoke that he's or she is injured, so not to move the head around a bit. Hypo wrap. This is pretty important. Everyone gets wraps no matter where they are. A traumatic patient in Tanzania with 39C is going to be hypothermic. So we definitely need to hypo wrap everyone. And well, HPMKs are awesome, but we're not seeing these in austere environments. So we teach a burrito wrap, which is very similar to what you probably seen. Or do you teach an improvised hypo wrap as well?
Yes, but the HPMK, just in my experience, HPMK, the ready heat blanket, that little system, like it is does not work that well. And I'm working in North Carolina in freaking July, and when we're doing our real runs, I've watched our patients like lose 2, 3, 5 degrees body temperature just because of the narcotics, the blood loss, the the etc.
Yep.
So we use a lot of wool blankets, and one thing on top of that we'll use is a hair dryer. And what we'll do is we'll make an improvised bear hugger.
Nice.
And so if you imagine patient litter underneath it, underneath that we'll drape a garbage bag, and we'll close so it's open at the head, closed at the foot, and we'll blow hot air into that. Do have to kind of not remove padding underneath the patient, but maybe thin it out some so that the heat comes up, and then pad specifically your pressure points. But with that hair dryer, like we have definitely gotten people from like really cold to like normal thermic in I wouldn't say a short period of time, but within a couple of hours of doing it. But just in my experience, and this is in North Carolina, you have a real sick patient, like they're going to get cold, and you have to jump on that thing so quick.
So a tactical hair dryer.
Yes. I got that from the Navy SEALs, and so
Of
they
course
have them
they know about hair dryers, don't they?
right?
Yeah, windblown hair. Yeah.
Right.
I'm going to have to try that. That's fantastic.
But that works really well. Unfortunately, you also have to have power. So
Yeah, but if you're out of a clinic, a Roll 2 or even a Roll 1E, you're going to have generator power, or you may have generator power.
hopefully,
And a lot of places I worked in Africa, there is power in pretty remote areas. You take over a clinic or you take over a house, you'll have it. So no, it's viable, definitely viable. You should publish that.
yes, of course. But I've not yet found like battery packs that have the outlets in them, not the USBs. But none of them have been able to generate the amperage to run a hairdryer off in it.
Tons of watts coming out of that thing.
Yeah.
Not that I'm an avid fan of hair dryers or know much about them, but if I remember correctly, don't they have an automatic shut off if it gets too hot? How do you keep that how to short circuit or to click that safety device that these hair dryers have to make sure that they don't overheat?
So never like shove it in with the patient, right? Because it's going to get so hot, you're gonna burn your patient. So if you imagine the litter, you secure it where the handle would be on the litter, and you've got some space around it to blow the air.
Right.
And then, so one problem I've had is fluids coming down, whether that be vomit or whatever. But fluids coming down, and if that gets into your hair dryer, it's going to short circuit. So, so imagine this wind tunnel, this plastic wind tunnel I've built underneath it. You put you put a hole in the bag, and then you put some kind of weight in the bag, so there's a low point, and the fluid will drain down that and go away from your patient, the head of your patient, away from the hair dryer.
So you are enclosing the hypo wrap around your hair dryer.
Not like tight
getting,
around it. It's open.
Not tight around it.
It's
I see.
open.
Okay.
At the
So
head.
that keeps it from tripping. Got it.
Right.
Yeah.
So you're just constantly blowing warm air towards the patient's core. And if it escapes around it, that's fine. I'm trying to capture that on my top blanket, where on top of the patient. So I encapsulate that. So any hot air is kind of caught and always around the patient.
Yeah. Wow.
And you just have to measure constantly what's their core temperature to see if this is working. Do I need to add more insulation? Do I need to start warming the IV bags? Things like that. I haven't done it, but I've heard anyway of warming up the Foley bag. So you warm the Foley bag, you raise the Foley bag above the patient, the urine runs back into the bladder. You let that sit for 10 minutes, and then you lower the Foley bag, the urine comes back, fills up your Foley bag, warm it again, and you keep playing this game.
Wow. So a lavage.
Yeah, kind of like a lavage, a urine lavage, but you're warming up the bladder, and so that's close to the core, and that's helping. That's more of an active rewarming than just warm air and blankets.
Yeah. Also publish that one, and you'll make some name, make a name, and make some waves. That's really clever. So we're not teaching any of that the wazoo stuff. We're just doing the general burrito wrap. But what we've found with the burrito wrap is making sure that all the leads off your devices are coming up past the shoulder. So we put the BP cuff upside down, so the pipes are running straight up towards the head. We put the stethoscope right underneath the BP cuff into the crook of the neck, tape it there. And even when you inflate the BP cuff, it doesn't occlude the lumen in the stethoscope, so you can still get a BP without having to open the guy up. So part of the problem we've had is losing so much heat that you just gained whenever you try to do an assessment, or so everything, your 3-lead ECGs, your SpO2, your pulse, everything is coming up to right next to is the ear. So you don't have to open up anything to assess them unless you're doing urine or something like that.
Well, I mean, you're gonna have to open it up. You're gonna have to, because let's say you got a guy with a junctional in there. If you ignore it, like I promise you, it's come loose, and you're gonna have to open it. You're just gonna have to work. Like I can't underestimate how hard you're gonna have to work to keep a real casualty warm, and you just have to be willing and think about things to keep more heat around him.
That's one of the benefits of live tissue, isn't it? You until you see that. The 7 years I spent teaching with Dr. Hagman and DMI, I learned tons of this kind of stuff. So the SimMan is 100 grand, isn't it? It's an amazing bit of kit, but it's just not going to get cold if you ignore it. So these are lessons that must be learned. Absolutely must be learned.
And you get to see with LTT, you get to see that lethal triad. He's cold. He keeps bleeding. Why isn't he making a clot? Because he's freaking cold. Warm him up. Readdress the bleed, trying to get it to stop and get him warm.
Simulations aren't quite doing that yet.
Yeah, I mean they can't. They can't. And they can't simulate the weird things that happen.
Yep, I agree. So that was HypoWrap. Let's move on to prolonged field care. And this one, I mean, there's tons and tons and tons you can do in prolonged field care on improvisation. So one of my favorites is the tuning fork for fractures. So if you have a 128 hertz tuning fork, and this is in PubMed, so I'm not making this up, but I've also used this extensively and had really good results. So like an avulsion fracture on a fibula, this is a good success rate on how this works. When you hit the tuning fork and you put the end of that tuning fork on the medial malleus, it's extremely painful because some reason the 128 hertz vibrating, when it vibrates against that avulsion fracture, just causes the bones to move, and it's really hurt. I can vouch personally on this, on my own avulsion fracture, that the tuning fork will definitely help you delineate, is it a strain or a sprain or a fracture. But on top of that, you can use this for long bones. So you have a stethoscope. For this guy has a tuning fork at the ankle. So you have your stethoscope along the tibia on the up by the knee. And as you move your stethoscope closer to your tuning fork, the sound will get louder. But if you are on the other side of a fracture, the sound won't be very loud until you pass that fracture point, and then immediately your tuning fork will be louder. And then you can do it the other way. It's fun either way. So you go up from, so you have your tuning fork and your stethoscope side by side, and you slowly move your stethoscope up the leg, and then suddenly the sound drops dramatically. There's your fracture point. It's a fantastic option. Is this something that you guys have used in the schoolhouse?
I used to talk about this when I first started. And it makes sense, like the 128 hertz, that causes resonance within the bone. And whenever you get resonance in any kind of structure, it vibrates, right?
Yep.
The Tesla thing where you tore down the bridge or the building, you had a device that caused resonance. So it makes that makes sense to me. Another option that doesn't make your patient want to slap you in the face would be ultrasound. And you dunk the ultrasound or dunk the limb in water, which of course we're just carrying water in containers everywhere. But with ultrasound, you can actually see the fracture. And
You can.
Now, is it important to know exactly where the fracture line is in like a tib fib or radius ulna or humerus or whatever? No, not really. But if you're thinking about the like the scaphoid in the hand or some of the bones in the ankle, those can be surgical emergencies per se, because like the scaphoid, the more distal it is, the perfusion for the scaphoid comes into the hand, and then back this way. It gets that's how it gets its perfusion. So the more distal the fracture is, the closer to the source of the perfusion to that scaphoid, which means like you really need to get that pinned, or you're going to lose the bone will die and you'll lose that scaphoid. So, and then there's some bones in the ankle that also do that, and I've forgotten the name of them, but being able to visualize that with ultrasound can tell you, is this somebody that I have to evac, or can I just put them in a thumb spica splint and it'll heal?
An ultrasound can be used without dunking in the bucket of water. You just get a 100 ml bag of IV. You take the bag out of the protective bag, and then you put ultrasound gel on the place you're looking. Then you put the bag. Then you put more ultrasound gel, and then you put your ultrasound. And that's going to space it out enough where you can see. So the tib fib fracture, it's right on the skin, isn't it? And if you just do ultrasound right on the anterior side, you're not seeing anything. It's just, you can't see that shallow. But you can throw a bag of saline, 250 or 100, and just make sure you put gel everywhere. Gel first, then bag, then gel. The rule of ultrasound is you need more gel, regardless of what you're doing. So I would take that ultrasound over the 128 megahertz, the tuning fork, of course, but always nice to have extra tricks in the bag. So let's talk about losing your ET tube connector. So I don't know how many times you guys have had this where you're BVMing somebody, or you have the tube in, and then you lose the bag comes off because maybe you're shocking the guy, and then you try to put the bag back on the ET tube, and the connector has been lost, and you're you're kneeling on it, or it's in the dirt. So you can improvise by wrapping 12 wraps of normal cloth tape and around the ET tube, and you'll be able to fit that ET tube back into the BVM and continue your cardiac arrest. Have you used this, or do you use just normal tape everything, tape the hell out of it to make it work, or?
Yeah, I mean, we're pretty knuckle draggerish. We'll duct tape the crap out of anything. But this is probably a smarter way to do it. In hospital, I've kind of had a situation where we've lost the ET tube connector, and I just remember being at the patient's foot and looking up at the physician at the head trying to do the airway, and the ET tube is gone, or the connector is gone, and we just kind of had a moment that we both panicked, and there just happened to be another ET tube next to us, so I like ripped it open and like tossed it to him.
Nice.
But when it happens, like it's a surprise for everybody. But I think having just understanding, hey, put some tape on that. Hopefully you're not bagging the patient actively when this happens.
Yeah, how long is it going to take you to do 12 wraps of tape around an ET tube? Meanwhile, the guy's not breathing. And
right.
You're losing cool points.
Yeah.
Ultrasound probe covers, and you can use a surgical glove, not an exam glove. A surgical glove, cut one of the fingers off. And Dennis, you said that the trick is put gel first, then the finger of the glove, and then more gel. You tried this last week.
Yeah. So I'm an idiot. So I just heard use surgical glove finger. And so I stretched that over the end and I put it down on a patient's chest, and I didn't see anything. And I was like, Aebhric doesn't know what the frick he's talking about. And so I ripped it off. Eventually I went back and I tried it to figure out, like, why am I an idiot? And then I, squirted gel in the glove, then put that on, which is a trick, by the way. And then use more gel, and then it worked.
Anything with ultrasound, you have to remove all air between the ultrasound and what you're looking at. So gel first, then the finger of the glove, and then gel, and that way you can continue on. So the reason we do this is, I mean, if you got a bloody patient, you just it's my personal IQ butterfly. I paid $2,000 for it, so I don't want to get somebody's gunk on it. So this is a really good trick to have a surgical glove in your ultrasound probe case, and just to make sure that you are not putting HIV or Hep C or anything else on the probe. You can improvise ultrasound gel. So the whole premise we said was you must remove all the air between your ultrasound probe and what you're looking at. So you can do this with a whole bunch of stuff: soap, with shampoo, cornstarch, KY jelly, anything at all, as long as it doesn't have bubbles in it. So the soap option, I've had good and bad success rates, because some soap is foamy, isn't it? So the shampoo will come out with holes in it, and you start looking with your ultrasound, and you're like, this is ugly, and then you're like, oh, that's because there's little bubbles in my what I'm using to improvise, and I'm losing cool points. So you got to make sure that it doesn't have any bubbles in it. So in our prolonged field care, we use Hitman, and T in Hitman is tidy, tubes and tidy. So we need to make sure that we keep our patient from looking with wires everywhere. And as a critical care paramedic, we got tons and tons of wires from 5 or 6 different machines going in front of, and it looks like spaghetti. And then you move the patient, or something happens, and one of those comes off. You don't know which machine it is that's beeping at you, and you got to follow the wire. It's just a headache. So you use an exam glove, and you cut up strips, or use some of the fingers of the exam gloves, and you tie the wires together so it doesn't look like spaghetti. So you can use this on a 12-lead ECG, as well as your SpO2 and your syringe pump, and your vents, and there's tons and tons of wires, you can use a glove to try to make it look a little less
Yeah.
chaotic.
So, especially when you're dealing with IVs and IV drips of different things, I mean, you can end up, with 3, 4 more IV lines, and they just get all tangled up. People checking things, people moving things, and especially during transport, it's a nightmare. It gets to be a nightmare.
Yep.
Using a finger glove, or a tabbed piece of tape, or some Velcro, or doing
clothespins.
yeah. Super smart. I would say, just as far as just organization, works super well. Be careful if you're tying your IV lines, because you can't trace it anymore. So what I do, I label the bag, and then I label wherever the admin ports are.
Nice.
So
Nice.
This is ketamine, this is resuscitation, this is whatever. So that when you have to do pushes or things like that, you know which is which. And so you're not shutting off one, injecting into another, thinking, you have the same line. So just labeling your lines, and then you can secure the crap out of them, because you already know which is which.
And you won't accidentally catch one, which we all have, and it keeps them secure. That's definitely part of prolonged field care. You need to make sure that your office area that you're working in, your desk, looks nice and tidy. So that means all your wires are kind of going the right where it needs to be, and paperwork's in order. Improvised otoscope. So prolonged field care, we need to look in nooks and crannies. So this is something where you can use a signal mirror with a light source that you can, and it takes 3 hands. So one hand, when you look in the ear, you have to make sure that the ear gets pulled back, so you straighten the canal that you're looking in. So one person, you have to get somebody, 18 Bravo or somebody, to pull back on the ear, and you can use the hole in the middle of your signal mirror to look in, and then you can use the normal torch or flashlight to look down to the ear canal or in the nose. Measuring marks on your stethoscope. I'm a big fan of putting some centimeter marks on the side of my stethoscope, so if I have to measure something, that I don't have to look around to see where my pen might have it on there, but it's good. And then the trick is, you want to put tape over top of that, see-through clear tape, to make sure that those marks don't get knocked off. Improvised tweezers. So definitely in wilderness medicine, we get tons and tons of things sticking out of us, and tweezers are the best option available. But if you don't have that, you can use 3 coins. So 3 quarters if you're in America, 3 loonies if you're in Canadian, and here in Europe, 3 50-cent pieces, and you offset them in such a way that you can use the 2 outer coins as a very good tweezer. So if you need to pull out something stuck in a splinter or something like that, you can improvise the tweezers to pull out grab whatever you need to grab. Another improvisation I like is making sure, this is definitely prolonged field care, is making sure I know where the hands are on a casualty. I don't know how many times in my 35 years I've been doing this, I've stepped on or kneeled on someone's hand. So I like the hands kind of out of the way. And I used to say, tape the thumbs together, but the tape gets sweaty because they're shocky, or the tape doesn't work. So one of my trips to Ukraine, I saw them do this. And what they do is they use a cravat or a triangular bandage, and they wrap it around both wrists, so the wrists, the hands don't flop out and you kneel on them. But what's really cool with this, if you have a semi-conscious patient, or somebody who's completely conscious, as soon as you immobilize the hands, their nose is going to itch every time. So you can't do soft restraints on casualties, because they need to kind of involve the environment they're in. They need to move their hands around a bit and then scratch their nose. So this Ukrainian technique I've stolen, and I'm now using that just to make sure that conscious or unconscious casualties. Their hands aren't flopping around a bit. So what are you using to bind the hands, Dennis?
Usually either just tucking them in your packaging, just keeping them tucked in. I would say just be cautious of the agitated unconscious patient, because just any agitated patient, just keep in mind, like, now you've made a big club and they can use both hands to beat you to death with. So if you have a really agitated patient, keeping them separate, one arm, one down, will help as far as keeping control of the patient.
Moving on, improvised splinting. SAM splints are definitely something you need, but if you run out of them, you need to be able to improvise splinting. So bandaging material. So the first thing we talked about was improvised tourniquets, and we do that with improvised bandaging. So we make improvised bandages by getting a t-shirt and just start cutting in a spiral. And you can, a t-shirt, you can make something like 15 feet long strip of bandaging material, as long as it's not any narrower than your palm, so 10 centimeters. So you can use this for splinting. And you can also improvise triangular bandages, and this is what we teach in Malta. So you can we cut up a shirt, we cut up we use a bed sheet, and we'll use a triangle bandage, our last one possibly before we use that, so as a form to trace out more triangular bandages. But we always add another 10 centimeters to the triangular bandage, because I'm not a small guy, so the triangular bandages that are out there are made for your 60 kilogram person, aren't they? And most of us walking in remote environments and doing offshore work, we're kind of big guys. So why not make a bigger triangle bandage when you make an improvisation? So you just want to make it a bit larger than the normal ones we have. What are you using triangle bandages, or what are you using for your disability stuff?
Yeah, I mean, we have our cravats and triangular bandages. I've taken, just uniforms, take the bottom edge of the uniform, pin it up to the shoulder, and that makes your sling. But like you mentioned, just cutting a triangular bandage bigger. Like, I've never personally run into the situation where it's like, I have so much material, I wish this was a smaller cravat. You can always just cut it if it's too much, but
True.
But definitely plenty of material. And I think just even spending just a moment thinking about how you can take that shirt and make it into, a nice strip of cloth, or, the pant leg or the whatever, and just spending a moment thinking about how you can do that is eventually will pay off.
I think it's important to have, we call it dirt time. There's a time on the ground doing this stuff. So even if it means your family members or somebody at the pub, so just try it out. Just grab some stuff and cut them up and see what works, and get really comfortable with that, because you never know when you might need it. So improvised splinting, we can use. You mentioned the using your own shirt. WMS has some good discussions on using your own shirt for immobilization and an upper extremity injury. So you can also use magazines, surprisingly strong. Once you roll up a magazine or make it into a U shape, you can use that for some splinting. I always have to mention duct tape. Everyone loves saying, "Oh, just use duct tape for an ankle." No circumferential duct taping ever. It's just the risk for swelling injuries is too big. Improvised litters. So WMS have some good good research on using jumpers or sweaters or jackets or shirts. And in my experience of working with this, you have to have long sleeve, and you have to tuck in the long sleeve of the jacket inside to stabilize. Otherwise, it tears. It just doesn't work. What has been your experience with some of the improvised litters?
Just my experience. Everybody thinks of them, especially like the tubular nylon, like the backpack type evacuation, especially when you're talking about like the different like really small unit people. But they always think, oh yeah, I'll just do this, I'll just do that, and they might know how to do it, but they never actually carried a casualty with it. And so, thankfully in the course that I'm in, I give them an opportunity to do the thing that you believe in, and this is part of your plan. Go ahead and do it. And each and every time they're like, this freaking sucks. Like we're just gonna bring a litter, So I would say whatever plan you have, test it out. Like find out, with something like that, the guy's you're going to end up essentially in a hammock where the poles squish into your patient because there's no cross support holding that litter out. So, which is okay. You just have to understand that this is what's going to happen, and find out how, like, you're going to have 4 people with that. Probably, I bet.
Definitely. In mountain rescue, 16 people is the minimum that they'll take. 16 people. And that's if they have a Stokes basket with a wheel on it. So you mentioned the using the sheet on one pole and trying to have a hammock type thing. It's just not going to work if you don't have something keeping that hammock from collapsing in on itself.
Yeah. So, and I mean, that's super common, especially at least from what I've heard. Like in Asia, I just talked to a guy in Burma, and like that's the normal thing that they do. But having especially if you're talking about somebody's got some kind of chest trauma and you're folding them into this hammock, he's not going to breathe so well,
Yeah. Yep. So that's the challenge, isn't it? You got a critical casualty. He's not getting out unless you put him in this hammock litter. But you put him in this hammock litter, and he's going to crump on you. He's going to start circling the drain. So what do? Do you walk 5 minutes and then lay him down so he can breathe for a bit, and then check vitals? And it's a challenge, isn't it?
Yeah. So I mean, can you, on inside that hammock, can you put like a puss pad or a backpacker's pad in there to help give it a little bit of rigidity of some kind and kind of push those sides out a little bit.
So duct tape is mentioned in Wilderness Medical Society for a litter, and I've tried this, and it doesn't work because both poles are closed in on each other, and it starts squishing the casualty from the side. So any improvised litter, you need to have some way to keep it open so it doesn't crush the casualty. And who carries that much duct tape? What is that? 2 rolls of duct tape to make a litter. Other improvised things, keeping vials safe. How many morphine vials have you broken in your career?
A lot. A lot.
So one option is using a barrel of a 10 mil syringe and keeping your morphine in there just to make sure it doesn't break. And the last few points I have for improvised are coming from our field guide. The Quorum Field Guide, page 308, we talk about the field hematocrit. You can use a heparinized capillary tube and spin it about 4,500 times is what I calculated, and you can just do an improvised centrifuge and to get a rough idea of a hematocrit. And this is something that we teach in Malta. And what I found is you need to tie one end of that improvised hematocrit to a door handle or to a tree or something like that, and then pull. It's a hell of a lot easier than trying to do 2 hands pulling in opposite directions. I'm not an SF guy anymore. I don't have the arm strength. So do it. Make it easier on yourself and put one end of this spinning hematocrit onto a solid device, and it'll be a lot easier. Have you tried this, Dennis?
No, I haven't. I mean, it makes sense. Just make sure that hematocrit, that that tube is secure, because once you start spinning it, like it's going to, and you haven't, it's going to sling out.
Yeah. So we do double of the normal putty that goes in the hermetic or the centrifuge, and then we use duct tape over the end, and it generally works pretty well. And then just got to be careful when you open it up again. Improvised clotting. Duke's method is from the World Health Organization. Duke's method of estimated clotted time. You poke a hole in the earlobe, and you see how long it takes for the bleeding to stop. And if it takes more than like 3.5 minutes to stop bleeding, you have a coagulation problem. The problem with this test, it only gives you one variable, and it's not very specific, but it's something that we found on the World Health Organization.
But is there anything else that you really want to cover?
We can stop there, brother.
Okay.
You know me, I'll just keep going and going and going. There's like 3 slides left. We'll stop at that.
But we're at
and you
2.5.
figure out how to end this thing. No way. Yeah, sorry, mate. All right.
That's all right. That's all right. It was a good one. But
Yeah.
I think important with all of this, practice. Like, you can't just have this like a card in your bag that says, hey, do these things, and then just follow it. Like, if you do that, you're gonna, in a time when you really need it to happen, it's gonna fail because you haven't practiced it. You got to practice it. Find out the finer points of its use and implementation, and these things I think we're gonna work out a lot better for you.
Dirt time. You need to spend time doing these skills.
Yep. Cool.
Thanks, Dennis.
Hey, thank you very much for coming on. It's almost like a Joe Rogan podcast here. It's like 2.5 hours.
Awesome. Thanks for the invite, brother. This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.